Well, good evening. It is 5 o'clock on my watch, and we'll go ahead and get started. A warm welcome to all of you. My name is Vineet Chopra. I am the chair of the Department of Medicine at the University of Colorado, and it is my pleasure to welcome you to a special event tonight that we're calling the COVID Expert Forum. I'm delighted to tell you that we have a record attendance today with almost 400 people who have registered, I'm sure in no small part due to our star-studded cast. I'm going to begin today with a few slides. I'll go over the current state of the pandemic in the United States and the world. And we'll then introduce our panelists to you, and then we will stop slides. We are going to have a fireside chat, an informal discussion, and a question and answer session with our experts. And I will direct questions to them on a wide range of topics, but I welcome your input and your questions as well. Please submit these using the Q&A function, which is being actively monitored by my colleague, Holly Kaiser. And we will be prompting those questions to our experts based upon where we are in our session today. Our webinar will be recorded and will be available for viewing after the presentation as well. So let me go ahead and get started. And I'm going to begin with just painting a picture of where we are today in the United States, in Colorado, and the world. And the story is not great. This is data taken from the New York Times this morning, looking at the number of COVID-19 cases in the United States. And you can see here, the numbers are terrible. We continue to see upward rises in the number of cases in the United States. And this is an increase by approximately 108% from 2 weeks earlier, which represents the Omicron variant that is now surging in our country. This is specific data to Colorado, and you'll see here a similar trend. At the hospital today, we are continuing to see higher volumes of patients. And although there's a little bit of glimmer of hope at the very end, we'll talk more about what that may mean for us looking ahead in our next few minutes together. Our story in Colorado is no different than what you might find in the country at this time. There are new cases all over, and this is hotspots, so areas that have high risk of transmission with high caseloads. And you can see certainly a lot of purple on this slide. This is again zooming into Colorado, and no surprise, you'll see that when you look at our geography, the number of cases that we have corresponds very closely to population density. So on the left, you have the number of cases, purple being high numbers, and on the right, you have bubble charts of areas of high caseloads. And for us here in Denver, you'll see this is where we are primarily located in terms of our care centers, and this is where we see a lot of our cases. Our community prevalence rate today is 37% as of this morning. It's the highest it's been in the pandemic to date. Hospitalizations for COVID-19 have gone up in the past couple of months. And again, this is a function of the Omicron variant. To be clear, they have increased almost twofold over the past 2 weeks across the country. And if you look closely at Colorado, you'll see that this increase happened in all age groups. This is another slide from the New York Times. We have 134 patients in our main hospital alone and over 300 in our system. And the key thing to point out here is those lines at the bottom, children under 18 and those in the adolescent age group, where we have seen record number of pediatric hospitalizations here in Colorado and across the country as well. Death is a lagging indicator, but the grim news is here. We are seeing an increase in cumulative deaths in the United States since the pandemic began. We have more than 5.5 million deaths globally attributed to COVID-19. And sadly, our numbers in Colorado for mortality are also rising, as you would expect, now that we're almost 3 weeks into our current surge. Deaths have increased 66% over the past 2 weeks in the United States. What about vaccination? One would hope the news would be good here, given how serious of a situation we're in. But if you look at our data, our vaccination rates continue to fall. We are now below 600,000 doses per day in the United States. And this number has been on the decline for the past couple of months, as you'll see here on the right side of that figure. We'll talk a lot about boosters today, but the question that remains is, where are we in terms of boosters in the country? About 30% of the US population is currently boosted, which means they've received their third dose of a vaccine that would be considered a booster dose. And this number, unfortunately, continues to remain relatively flat over the past month since we're dealing with Omicron. And so not surprisingly, when we look at what's happening in hospitals, the number of ICU cases and the number of deaths in the ICUs and across the country continue to trend in the wrong direction. But it's not all doom and gloom. I want to point out 3 statistics here from today's data, specifically looking at the peaks of these surges. And these green circles here look at Colorado, New York, and New Jersey. And in general, we lag 2 to 3 weeks behind the East Coast, but there may be a glimmer of hope with respect to cases in our hospitals, reflecting on what's happening on the East Coast as well. We'll talk more about that with our panelists today. So I love this quote: "We should learn from the past, we should prepare for the future, but live in the present." And in that vein, I am going to now introduce our 3 outstanding panelists that we have here today. First, I'll introduce Dr. Carlos Del Rio. Dr. Del Rio is the Leon L. Haley Jr. Distinguished Professor of Medicine in the Division of Infectious Diseases at Emory University School of Medicine, where he's also Executive Associate Dean for Emory. He's a Professor of Global Health and a Professor of Epidemiology at the Rollins School of Public Health. During the COVID-19 pandemic, Dr. Del Rio has been a leader locally and nationally, conducting research, developing policies, writing scientific publications, and making countless media appearances. One as late as yesterday, I saw on CNN. Dr. Del Rio has advised municipal, state, and national leaders, including Atlanta Mayor Keisha Lance Bottoms, the Tyler Perry Studios, the NCAA, the USTA, Delta Airlines, among others. We're very, very grateful to have you here today, Carlos. I want to also introduce Megan Ranney. Dr. Ranney is the Warren Alpert Endowed Professor of Emergency Medicine at the Alpert Medical School of Brown University. She's founding director of the Brown Lifespan Center for Digital Health. Clinically, she's an emergency room physician and is still seeing COVID-19 patients in the ER and tweets about them regularly. She's a prolific researcher, a national advocate for innovative approaches to public health, and also the academic dean at the School of Public Health at Brown University. Dr. Ranney's research is focused on developing, testing, and disseminating digital health interventions to prevent violence and mental illness. She serves multiple national leadership roles, including being co-founder and senior strategic advisor for Affirm at the Aspen Institute, which is a nonprofit committed to ending gun violence through a nonpartisan public health approach. She's also president of the board of GetUsPPE.org, a startup nonprofit that delivered donated personal protective equipment to those who needed it the most. Welcome, Dr. Ranney. And last but not least, Dr. Kritika Kopali. Dr. Kopali is an infectious disease physician and medical officer for COVID-19 in the Department of Epidemic and Pandemic Preparedness at the World Health Organization in Geneva. She's an infectious disease researcher and a COVID-19 expert at the WHO and has an extensive background in emerging infections, global health, and biosecurity. Dr. Kopali has been called upon by the US Congress to provide scientific-based guidance and dispel myths about COVID-19. At the World Health Organization, she works with the Clinical Characterization and Management Working Group for COVID-19, the COVID-19 Therapeutic Steering Committee, and the Post-COVID-19 Condition Steering Committee, the latter of which she leads. She's also a member of the Secretariat on the Scientific Advisory Group on the Origins of Emerging and Re-emerging Infectious Diseases, which was convened by the Director General to understand the origins of SARS-CoV-2 and other novel pathogens. So welcome to all of you. Thank you for joining us this evening. I'm going to start by asking us about the elephant in the room, and that is Omicron. So Carlos, what do we know about Omicron versus Delta? What's different about this variant?
You know, I think that many things are different. One of the things is, to me, the most striking one is how incredibly infectious this variant is. And I think I've never seen anything in my life from an infectious standpoint being so infectious. And this is why many people say, look, I've been doing the same things that kept me safe up to now. I wear my mask, I do this and do that, and I still got infected. But the problem is the sort of the enemy changed, right? The virus changed. And when the virus changes and becomes much more transmissible, much more infectious, you really, if you truly want to remain uninfected, you have to change what you do. So that's why, and we'll talk about this later, that's why CDC has updated their masking guidelines. That's why a lot of things have changed. And I think, to me, one of the most remarkable things in this pandemic is to think the virus that emerged initially and where we are right now, the evolution of this virus from an evolutionary biology standpoint, we've never seen anything evolve so quickly, so differently, and so rapidly. And as we will talk later, one of the challenges that we have is the vaccines that we have currently were designed for the ancestral strain, were designed for the strain that emerged. And where we are right now, we have a different virus, and therefore the vaccines are not as good simply because we're not dealing with the same agent. So to me, that's the one thing, is how infectious it is. The second one is, could it be less severe? it may be, but I think we have to take that with a grain of salt because it's less severe if you're vaccinated, but if you're not, it could be just as severe. But clinically, what I've seen, a couple of things that strike me, the symptoms are a bit different. Sort of the loss of smell and taste is very rarely seen with this compared to like the ancestral strain or Delta. The second thing is you don't see as much pneumonia. This appears to be more of an upper respiratory virus than a lower respiratory. And there's some animal model data suggesting that this virus is not as good as getting to a lower respiratory tract. The third thing, when you're in the hospital, like in the consult service in the ICU, I'm seeing less people with the cytokine storm. The huge cytokine storms that we saw before are less likely to occur with Omicron. So, does it less severe? Maybe it is. But the immune evasiveness is the other thing. But I think when I think about immune evasiveness, we talked about the vaccines. The other thing is that prior infection that used to give you a certain level of protection against Delta may not be giving you enough protection against Omicron. So the immune protection is also more broad than it's ever been. So in that respect, we're really dealing, and I think this is an emphasis we need to give to people, we're dealing with a different beast. And therefore, our recommendations have to change, our advice has to change, and our response has to change. And that's what we're going to be talking about today.
That's great, Carlos. So Megan, you've been in the ER taking care of these patients since the beginning of the pandemic. Are we, in your mind, also dealing with a different beast based upon what you're seeing?
So I'll say that from the perspective of the average emergency physician, this looks pretty much the same, right? So certainly on a population basis, we're seeing less pneumonia, less cytokine storm, but the folks that are coming through the doors of my emergency department, I'm seeing the same hypoxia, I'm seeing the same acute kidney injury, I'm seeing the same microthrombi and strokes, pulmonary emboli. So the folks that are coming in and needing to be hospitalized look so similar. The big difference, of course, is that those of us who are getting ill in the community who have been vaccinated, particularly those of us who've been vaccinated and boosted, are experiencing a dramatically different illness. And I've been joking with some folks that this may be the virus that makes some of those naysayers statements at the beginning of the pandemic around, oh, it's just like the flu. Omicron in some ways is more like the flu than the earlier, to Carlos's words, ancestral variants were, but it's still not just the flu, right? So there are things about it that are different, but even though it's milder, by the time that you end up sick in the ED, it's the same. The other thing that I think is really important to emphasize here, and you showed it in your slides at the beginning, and Carlos said it, but it's worth re-saying, and I think probably everyone on this webinar tonight knows it, but I feel like we can't say it enough right now, is that although overall on a population basis, Omicron may be landing a lower percentage of people who get infected in the hospital, the reality is that our emergency departments and our hospitals are seeing similar numbers of hospitalized patients and intensive care unit patients as we were a year ago. So although it may be milder on a population level, our surges are the same. And as you mentioned, we're doing so with fewer staff, right? We've had more staff leave. We have more staff who are acutely ill, more callouts on a daily basis. So sadly, my reality is essentially the same.
So a population perspective to a hospital level perspective. Kritika, you're at Geneva, you're looking at it in a global perspective. What are you seeing globally in terms of Omicron?
Yeah, so overall, globally, we're seeing cases surge, and it's really being driven by Omicron. Over the past week, we've had almost 19 million new COVID cases reported globally, and that's the most we've ever seen. And this represents a 20% increase over the prior week. And the trend of new deaths also remains the same, though. So to the point that this may be less severe, we're seeing about 45,000 deaths per week, but now seeing over 3 million new cases a day. And so for last week, we had like I said, the highest number of new weekly cases reported globally. And all regions are reporting an increase in incidence of weekly cases, with the exception of the African region, which reported a 27% decrease, which was also seen a decrease the week previously. So we are keeping an eye on that. The other thing that we also are noticing is in this last week, there was an increase in deaths in Southeast Asia by 12% and in the Americas. So that includes the United States and South America by 7%. So, definitely some increasing trends and that we're noticing on a global level.
That's great. And it's interesting to see how it varies by regions based upon what we're seeing in terms of cases and infections. Carlos, why? You mentioned this is a different beast. Those were your words. Why is it so? What is it about this virus that makes it behave differently? You mentioned upper respiratory more than lower respiratory, less cytokine storm. What do we know about this that makes us understand why it behaves as differently?
Well, we see in Omicron has close to, over 50 mutations in different parts on the receptor binding domain, on the nucleoprotein level, et cetera. And those are the things that have made the virus probably very different. But in addition, as Megan said, there's also the component that many people aren't vaccinated. So if you're dealing with immunity, it's not just the virus, it's really the combination. And one thing, for example, it clearly may be a much less severe clinically population level. I like what Megan said, a much less severe. What we saw in South Africa, you have a much younger population. You have many people that have previously had infection. So you have, again, I think we're looking at how this virus interacts with populations in a very different way, depending on the population. The one thing I again want to emphasize is what we're all seeing and what Megan said, because this is highly transmissible. Dr. Fauci said the other day, we're all going to get it. And I'm not sure we're all going to get it, but we're all going to be exposed to it. You're getting exposed to this virus. And if you're going to get exposed to this virus, you're better off vaccinated than unvaccinated. Because the reality, if you're unvaccinated, you may have just a severe disease as anybody else in the past. So, we need to dispel this myth, unfortunate myth that started way back in, right after Thanksgiving from South Africa. Oh, this is much less severe. People don't end up in the hospital. We don't need to worry about it. And I think it also, it's sort of once something gets in the news and stays there, it's so hard to retract it. I mean, we have spent so much time trying to withdraw that statement that this is less severe. Then, and there are people wondering, well, why are you so busy in the hospital? This is less severe. And then the whole thing has come around, this whole issue. Well, there's people with COVID and there's people there, that just are infected versus having disease. And it's so hard to explain that no, people are, as Megan said, are really sick still. And if you're unvaccinated, we're seeing them in the ICU, they're dying, they're sick. The good news is we have more vaccinated people.
So let me ask them the magical question, right? So we're all gonna get exposed. Some of us will get it, some of us won't. Megan Kruzika, is this our way out of this? Is that we're gonna have this variant sweep over, everyone's gonna get exposed at some point, and we'll have, what is the word, herd immunity or some degree of magical immunity to this variant?
So I'm gonna remind us that it's been since Easter of 2020 that people have been declaring that we're going to be out of this in 2 weeks. And I feel, I don't have a crystal ball. None of us do, including sadly you. I'm sure your department would be thrilled if you did. But sure, it's possible. It's possible that this will be the variant that causes herd immunity, but honestly, it's unlikely, right? And the worst thing that we could do is say, oh, just go out and get Omicron and then you're protected forever. And we're finally through this and we're on the other side. It's like chicken pox, do that party and expose your kids. There is absolutely no guarantee that A, getting infected with Omicron is going to cause durable immunity. B, that there's not going to be a new mutation and variant that gets around whatever immunity Omicron causes. C, that any of this is not going to completely change in a month. I went on TV on Thanksgiving morning at 6:30 in the morning, and someone asked me about new variants. I hadn't logged on Twitter at that point. And I was like, oh, the amazing thing is, Delta is so transmissible and it's outperforming any of the other variants since. And I literally got off TV and opened Twitter and was like, oh my God, South Africa just, the South African kind of equivalent of the CDC just kind of declared that Omicron was in the world. And I think it's such a reminder about having humility, about thinking that this is ever going to get to this endemic state. And let us also remember what endemic means. Endemic is, a lot of folks say endemic is like the flu. Endemic just means that it's at this constant low level. It doesn't mean that we're having these outbreaks and surges, which is what we keep experiencing, even with Delta. Even once Delta had, gone through our entire population, we then saw new surges across the South and Southeast. And then it came into the North and Northeast this fall, just prior to Omicron. So even if Omicron does come through and we don't have no new variants and mutations for a while, it doesn't mean that we're through the woods. It doesn't mean that we've hit that fabled endemic state that everyone wants to, say that we've reached. I think the worst thing that we could do is to fail to plan for another surge, because based on, I'm interested in Carlos's and Kritika's opinions, but based off of kind of everything that I've read, studied, and experienced, I think it's inevitable that we'll have more to come.
Kritika, this is your moment to endear yourself to lots of people by going against the wills of Carlos and Megan. How do you feel about this?
Yeah, no, I mean, I agree with Carlos and Megan. I think the one thing that we have learned about this virus is that we're unable to predict what will happen next. And the best thing that we need to do is remain proactive, plan, and continue to use the tools that we have. So vaccines and all the public health and social measures. And, the other point that I want to make is, we have not done a good job of not just vaccinating here in the United States, but vaccinating the world. And if we don't vaccinate the world, we're going to continue to see other variants emerge. And we're going to see high levels of transmission. And I just pointed out that we're seeing upwards of 3 million cases in some days, right? 3 million cases is not endemic, right? We're seeing our hospitals overloaded. That's not endemic. And so we're not near reaching an endemic state at this point. And unless we do the things that we've been talking about for the last 2 years, which is getting people vaccinated and reducing transmission, we are going to see other variants. That's just a matter of fact. And we don't know if that next variant is going to be more transmissible, more virulent. We haven't been able to predict what's happened with this virus yet. And so I think we need to be vigilant and remain proactive.
And if I were to add to that, I think Kritika is absolutely right. I think the U.S. we have done a terrible job. The world has done a terrible job, but the U.S. in the past had typically had a great leadership role in global health, and we just simply haven't had it. And while you're hearing the administration saying, "Oh, we commit to 2 billion doses giving, globally," the reality is the U.S. has given 300 million doses globally. That's it. I mean, and we're treating it as charity instead of really part of the strategy. And without having a global strategy, we're not going to get to end this pandemic. And I think that's been a huge failure of the administration, and one that, quite frankly, I hope that they correct. But they seem to be too focused on what we do here and not what we're doing globally. And this is a pandemic. The one thing, though, Vinette, is that because this has been so difficult to predict, almost impossible to predict, I fear and I feel for businesses, I feel for our universities, I feel for anybody trying to plan. I feel for people trying to plan their vacation this summer, right? I mean, we all like to make plans. We all want to know, gee, what's going to happen? You cannot believe the number of emails I have. I'm planning to go to Europe this summer. Do you think I can go? Gee, if I knew the answer to that, I would be in Las Vegas, right? I mean, the reality is it's really hard to plan. So one of the things that this pandemic has shown us, as Megan says, humility. But the other thing is to live the day. And I think we need to learn to live where we are today. And the plans need to be flexible, need to be at the moment. And if you can do something, great. And if not, you need to think about retracting. I mean, today, I'm part of the organizing committee of this really big meeting in HIV called CROI. And today we send the email out. We finally made the decision of going virtual. We were all hoping to be in Denver by middle of February, and that was where the meeting was going to take place. And I was looking forward to go to Denver in middle of February. And it may be totally safe to go to Denver in middle of February, but at this point in time, based on the available data, the most prudent thing to do was to cancel the meeting. Not an easy decision, but a difficult decision. And I think that's part of the problem, that all of us who are like making decisions with a lot of data, all of a sudden is we don't have the data. So that's when I think we physicians feel a little more comfortable, because our clinical practice on a day-to-day basis is making decisions with limited data. And therefore, you have to tell people how we make that decision-making process. And I think we haven't been very good at doing that, at explaining to people how the decision-making process is made with imperfect data.
Yeah, the humility of uncertainty, Carlos, I heard, and I heard carpe diem in terms of live in the moment. You mentioned Denver, so let me give you sort of a reality check on where we are today. Last week on Friday, we declared crisis standards of care in our emergency departments. We didn't have enough staff, space, or equipment to take care of them. And there's been a lot of talk about hospitals in the news. So let's talk about hospitals for a second. And specifically, let's talk about the CDC's new isolation guidelines. So the CDC recently came out and said, healthcare workers, if they're feeling well and are not otherwise sick, but have been positive at the end of 5 days, could return to work. This has generated a lot of buzz and chatter. We've already got some questions about this from audience members. I'd like your thoughts on this approach from the CDC. What's the thought process here? And maybe Megan, I'll have you kick us off.
Ooh, how lucky am I? So this is a great example of what Carlos was just talking about, making decisions based off of imperfect data. There's a couple of things. One is that there's science actually coming from the NBA. Carlos, thank you for advising them. There have been a couple of really great papers, some of the best kind of population level papers that we've seen around the duration of infectivity. There's a paper in late December that suggested that the mean duration of infectivity was around 5 days. It was a little lower for people who were vaccinated and lowest for those who were vaccinated and asymptomatic. Based off of that, plus the coming Omicron surge, that's why the CDC changed their recommendations. They were based off of both the science and the economic reality that expecting that Omicron was going to spread as quickly across the United States as it had across Southern Africa and as it was spreading across the UK, we were literally going to shut down as a country if everyone had to be in 10-day isolation. And knowing that data from the NBA, they said, well, it's probably safe for folks to break isolation at 5 days if they remain masked from days 5 through 10, and they are asymptomatic at day 5. There was some internal debate I've heard around whether or not to make rapid testing part of that protocol for breaking isolation. We all know that rapid testing is an amazing tool for demonstrating acute infectivity, although we can debate separately about how good it is with Omicron. We also all know how difficult it is to get those rapid antigen tests right now. And so rapid testing was not included out of both practical considerations and those concerns about how accurate the tests were. That's what led to the 5 days. If asymptomatic, you can come out of isolation, but make sure that you're fully masked. Those recommendations were initially applied to just healthcare workers, then expanded to the country at large. And then, of course, the messaging kind of went off the rails. There were different pages on the CDC website that conflicted with each other. Is it that you have resolving symptoms or are you asymptomatic? Is it just that you have to be fever-free, right? There were conflicting pages about what is true for K through 12 versus healthcare workers. I will say at the end of the day, what I am telling folks, family, friends, and colleagues is if you are still symptomatic, please do not come out of isolation. And I'm advising businesses to not force their employees back to work when they are still symptomatic. A, they're going to get people sick. B, they're going to stay sick longer. So it's not going to help anybody in the long run. B, if folks are asymptomatic and able to come back to work, make sure they have a high quality mask on. That was not part of the CDC recommendations. It just said masking period, but it should have been a high quality mask. KF94, KN95, or N95, and it should be worn nonstop. I will finally say here, this is the problem with sending school kids back after only 5 days. We know school kids eat lunch together. We know that our coworkers eat lunch together, even though they shouldn't. And so they're bound to transmit together if they are one of those folks that has lagging infectiousness. Last thing I'll say is that there was another paper out from using the NBA data just, was it yesterday, 2 days ago? That's a preprint that shows, not surprisingly, that Omicron, the duration of infectiousness actually there's a longer tail than there was with earlier variants, making these new recommendations even a little more concerning. But it's this balancing act, right? Between we can't have hospitals shut down, we can't have grocery stores shut down, we can't have the postal service shut down. If people are truly asymptomatic and vaccinated, it may be safe for them to be back with masks on. And the reality that we don't want to spread it further. So I'll stop there. I'm sure that Kritika and Carlos have additional thoughts.
So can I just clarify, when you say asymptomatic, what do you mean?
So great question. No cough, no fever, no body aches, no sore throat, no headache.
So feeling normal, basically.
Feeling pretty much normal. And I'll actually say, so this is anecdotal. This is not published data, but anecdotally, all my friends and colleagues who've caught COVID and happen to have access to rapid tests have been testing once they start getting past that 5 day. And they'll say to me, Megan, I'm 6 days, I'm still positive. And then magically the day when they truly feel back to themselves, they stop having positive antigen tests. It's amazing when you're asymptomatic, right? Again, anecdotal, not published. But the folks, at least kind of, I would say 24 people who, when they've hit that true asymptomatic, their antigen tests have turned negative. But I mean truly asymptomatic, not like not our usual healthcare. Oh, I'm not dying. I don't need to be hospitalized. Therefore, I can go back to work.
I'm only on 2 liters. I can do this shit.
Exactly.
No problem, right? We're the guy, Carlos, jump in. Thoughts on this?
You know, I'm basically in agreement. I think the issue was, as Megan said, you know, I think part of this problem in this pandemic has been public health versus the economy. And I think one thing we have learned is that public health is important to support the economy. And, you know, we all saw hospitals are going to run into serious problems with people being sick, and other businesses were going to do the same. And what CDC had not done is they hadn't updated their isolation guidelines in September. And it's very different, you know, even with data saying vaccinated people are doing better. So in fact, I was in favor, I've been in favor of saying you treat vaccinated people different than unvaccinated people. And in healthcare, most of us are unvaccinated, but a few people are still unvaccinated. We don't, at least at Emory, we don't follow this 5-day rule in them. We say, and what have we done at Emory? We've gone to a 5-day, and then if you feel better, as Megan says, you can get tested and come back to work if you're negative, or you go 7 days and you don't get tested. But it only applies to vaccinated employees. And again, you need to be fever-free without any antipyretics. You need to be not coughing. You need to be essentially feeling well, even though some people still have a little bit of a nasal congestion. As somebody said to me, it feels like I still have allergies. Well, you know, that's all you have. Yes, you can come to work, but continue to be masked. Again, we're in an environment in which everybody's masked. But what Megan said, I think, is a really important point. People get together to eat. People, you know, we need to remind people, if you're one of those that is coming back, we need you not to get together to eat with people. We need you you need to follow some special precautions. And we're also, for example, not letting you go back to work in the bone marrow transplant unit. I mean, we make sure we put you in different places, right? So we're giving our hospital epidemiologists some control about how to manage those return to work employees. But it has allowed us to have some people. I mean, I can think about a colleague an emergency room physician who tested positive and pretty asymptomatic. By day 3, this person said, I feel totally fine. I know my colleagues are out. I need to go help. I want to go help. By day 5, this person was able to come back. Before, it would have been 10 days out. And I think if we stayed at 10 days, we would have essentially been, I mean, we've been in, forget about crisis standards, we would have been in serious patient care quality standards.
Ritika, any thoughts on this from your perspective?
Well, I will say that, you know, WHO, we do have isolation guidance, and you know, given all the concerns that have been raised about trying to maintain workforce and maintain economy and that people have, and we are currently looking at the evolving literature and considering how we can adjust our guidance in the role of testing and releasing individuals from isolation. So that is something we are considering right now.
So you all mentioned masks and you all mentioned CDC. So you're setting me up for my next question beautifully, which is just 4 days ago, CDC changed their masking guidance and recommendations. And they essentially said something very different for the public, something very different for healthcare workers. Carlos, walk us through this. What did they say? And what is our takeaway from this, given our conversation around coming back to work at 5 days?
You know, I tend to tell people use a high quality mask, and that to me means a multi-layer mask that fits you well, that creates a good seal on you, and wear it appropriately. Because, you know, again, you know, the other day I was at the airport and, you know, many people had their mask under their nose. Well, if you got an N95 under your nose, it's no good, right? So you got to wear it well. It has to fit appropriately, and it needs to be a high quality mask, i.e. a multi-layer mask. And if that happens to be a K95, a K95 surgical mask, and if you want a double mask, I mean, but protect yourself in such a way that you're wearing a high quality mask and wear it correctly. The problem is that, you know, in healthcare, we have certain regulations in which, you know, if I'm going into a COVID room, at this point in time, I'm wearing an N95 mask. Now, we have so many people in the hospital that currently I'm wearing N95s all the time when I'm rounding, right? And if I'm in the emergency room, we tell our ER physicians, you don't know who's coming in. You might as well just protect yourself appropriately. But it may be very different that if you're the person, you know, doing transport, or you're the radiologist, or you're so I think we need to have also the flexibility of how do you apply the rules. And again, what we found in healthcare, and I would love to hear what others say, is that we're not seeing people get infected in healthcare. We're getting people in healthcare and getting infected in the community. And again, the issue is that it's in the community when they're not wearing their mask, when they're getting infected. So the quality of masking, in my mind, is less of an issue than the appropriate use of masking of a good mask. And whether we get into the details that is this mask or that mask, I think we're trying to really complicate things, honestly.
Megan, I saw your thumbs up. So
I gave the thumbs up to the community spread, and I'll say this is true for schools too. I'm involved in an awful lot of discussions with schools, and we're finding that with good masks and protocols, that there's less transmission in schools, in universities, in the work setting, right? And I saw one of the questions in Q&A about kind of why are we coming back? It's because truly, if you are following these non-pharmaceutical intervention protocols, if you have the combination of vaccination plus good masking plus ideally ventilation as well, the chance of transmission in the workplace, in the school, in the university is so much lower. Where people are getting sick is out in the community. That said, I actually am quite happy to see the update to the CDC recommendations. It's funny, back when they first started recommending cloth masks, I had a bunch of discussions with people pushing back because of, cloth masks are better than nothing, but they're certainly not as good as surgical masks or N95s. The reality was at that point in the pandemic, we had nothing. And so cloth masks were better than nothing. And I will still say, wear a cloth mask instead of nothing. But there is a good, better, best hierarchy. And it is cloth masks, surgical masks, and then kind of the KF94, KN95. And obviously best of all is our fit tested N95s that we all hopefully wear in the healthcare setting. Anything on that is better than the thing below. And so to me, it also depends a little bit on what your risk level is. If I have, to Carlos's point about someone, who's status post transplant on immunosuppressants, the vaccines may not work well for them. I am going to super insist that that person wears the highest quality mask that they can wear all the time. For someone like me, who's relatively healthy, not depending on how my kids would argue with me, but not old, right? A surgical mask when I'm running out for a quick errand, probably fine. But understanding that there is that hierarchy is important, and I'm thrilled that the CDC finally endorsed it. I do think that people get super caught into this like hair splitting, which doesn't help anyone, arguing about is a KF94 or KN95 better. Ultimately to Carlos's point, the mask you wear is better than the one you don't.
what about double masking? Do you do it?
I don't personally, I double mask when I'm in the ED because that way I have like my surgical mask that I can take off and, because I wear the same N95 for an entire shift. But out in public, I don't really, but I'm also not spending hours out in public in a public setting for the most part. If I were a school teacher, I would probably wear a KF94 or KN95, might wear a surgical mask on the outside to help preserve it, again, just for being able to take it on and off and having less concern about contaminating myself as I did so.
Carlos, what's your policy for masking at Emory for healthcare providers?
We say surgical masks for everybody. And if you're taking care of patients with respiratory illnesses, wear an N95, a fitted N95.
Okay. Kritika, anything to add WHO guidance on this, or where is the WHO on masking?
Yeah, so the WHO just released updated guidance right before the holidays for both the community and for healthcare workers. And for the community, they issued a strong recommendation for where there's in the community for wearing a mask irrespective of vaccination status or history of prior infections. So, and again, to what both Carlos and Megan said, it's really wearing a well-fitting mask that covers your nose and your mouth, right? So whatever mask you choose to wear is better than the mask you don't wear. And then the healthcare worker guidance also came out right before the holidays, and recommending again, a respirator or medical mask should be worn by health workers along with other personal protective equipment. But if you're caring for somebody who does have COVID, it should be a respirator along with PPE. So that's all new guidance that came out.
That's terrific. So the best mask you have is the one that fits you the best. Doesn't matter if it's a surgical mask or an N95. And if you're in a shift where you're touching your face, Megan, wear a surgical mask to protect the N95 more than anything else is what I'm hearing. Let's talk about testing next. And I'll tell you a personal story. I have 2 children at home. One of them had sniffles the other day, and we had a conversation in my house. My wife is watching right now, so she can attest to this, about should we burn a test? These are hard to find. The symptoms were mild, but he goes to school. it's hard for us to figure this out in terms of what we do. And it's just hard to figure out, when you should versus should not test in the setting of constrained resources. Now, I know the government today has released their COVID testing kits, and all of us here have ordered ours, which is great. But Kritika, walk us through, what do we know about antigen testing with Omicron? How good is it to begin with?
Yeah, so this is something that WHO has been looking at since we first declared Omicron a variant. And so the diagnostic accuracy of routinely used PCR assays does not appear to be impacted by Omicron. I think we all know that one of the PCR assays, you'll see estrogen target failure with Omicron. We know that there's some preliminary data suggesting that some rapid diagnostic tests are less sensitive at detecting Omicron compared to other variants, but they are similarly other studies that show no difference. So we're working within our expert networks right now to ensure more robust data is available to understand whether or not this is true, and then what the mechanism would be to see if Omicron may impact the accuracy of these rapid antigen tests.
So Carlos, walk us through false negatives, false positives. What do we know about this with Omicron?
Well, I mean, first of all, let me say that I think rapid tests are a huge resource to have, are a great resource to have. It's part of our public health strategy. And part of the problem is that in our country, we have looked at it, and the FDA looks at them as diagnostic tests, right? And compares it to PCR. We don't have a way to look at this as a public health intervention. And it's a little bit like we talked about masks. There's this quality, there's different gradings. Well, with testing is the same thing. You have some tests that are here, some tests that are better. So of course, if you compare a rapid test, a rapid antigen test to a PCR, your PCR is going to be much better. It's going to be a lot more sensitive, but may not be as good once you get out of isolation at 5, 6, 7 days. I mean, I know many places that are still requiring a negative PCR. Some nursing homes are requiring a negative PCR before accepting a patient. It makes absolutely no sense, and we need to change that behavior because it really is impeding. And we haven't talked about this. At least at my hospital, we have a lot of patients where we're unable to discharge because they came in with COVID, and now nobody wants to take them after a stroke because they're still testing positive for COVID, right? And they're testing positive in the PCR, and the nursing home won't take them. So that's an issue we really haven't discussed, but it's causing a problem for us. So rapid tests, what you said, if we had availability of rapid tests in your situation, great use of a rapid test. That kid, I can give you my personal experience. My daughter-in-law in Miami, December 21st, developed sniffles. She immediately tested herself, rapidly found out to be positive. My son and her daughter, a 1-year-old daughter, isolated, rapidly separated. Nobody else in the household got infected. So again, a rapid test was a very useful tool to make a diagnosis. And I remind people, the 3 I's of responding to an infectious disease are information, identification, and isolation. And the identification comes from testing. And if you need to stand in line for 2 hours and then wait 3 days for a test result, it's a useless result. And that's the benefit of a rapid test. Now, we need to tell people, if you have symptoms consistent, if you have a fever, you have nasal congestion, you have cough, and you test it and you're negative, you may still have it. And that's why if you look at the rapid test packages, most of them come with 2 tests. And it's not because you need to test yourself and your partner, it's because you test yourself, and if you're negative, you test yourself again at 24 hours. So by testing doubly, you're actually increasing the accuracy of the test. So I think you need to use this resource appropriately as opposed to use them the wrong way. Many people, for example, I think about, went to visit my mother who's elderly. Well, I tested myself 24 hours before I went to see her, and then I tested myself literally as I was walking into her house. And by having 2 negative tests, I was pretty comfortable that I can go and not bring disease into her. And so using the test appropriately, I think it's a huge public health tool to prevent us from transmitting the infection. I think, the tests are pretty good with Omicron. They're not perfect, but again, that's a characteristic of the test. These are not perfect tests. These are public health tools.
So when you went to visit your mom and you had 2 negative tests, you kept your mask on when you saw her?
No, I took my mask off.
Okay, all right. So the testing gives you that assurance then that you tested 24 hours apart.
I feel pretty comfortable that after 2 negative tests and being asymptomatic, I could go and take my mask off.
Yeah, I think the challenge for all of us has been finding these tests. We've all seen the signs in the pharmacies about, sorry, we're sold out. But Megan, walk us through maybe that thought in terms of the testing, and then I think maybe talk a little bit about saliva testing, because that's come up as a potential win for Omicron, given that we know it's more upper respiratory. What do we know about that?
So, I mean, saliva testing, we don't have the at-home saliva tests that are approved right now. So it's a little bit of a theoretical that this swabbing the throat or taking that saliva may be more sensitive. There's also the question of how much it matters, right? So when you think about tests, so there's, what are you actually telling yourself if you have a positive saliva test or a positive throat test? Does that actually mean you're infectious? The other thing I'll say about the throat swabs is that the rapid antigen tests are not FDA approved for swabbing your throat. We don't actually know. So you may test positive. It doesn't actually mean you're positive. That's not what they've been tested for. I really want to emphasize Carlos's point, which is if you're symptomatic, stay home, regardless of what your test shows. I see that being a far more common concern or issue than the false positives. It is false negatives. And if you're symptomatic, whether or not it's COVID, you don't want to be out and getting other people sick right now. I think of it as the same thing as, again, not to say that COVID is the same as the daycare crud that my kids used to bring home, but it's the same kind of thing. If my kid had a runny nose and a cough, it was irresponsible of me to send them into daycare, regardless of whether or not they had the flu or whether I could get an RPP and say they had adenovirus. You just didn't want to expose other people to it. And the same thing is true now. Sputum, saliva, it may certainly be coming down the pike. I am not deeply involved in FDA approval process. Krutika and Carlos may actually know more about where we're at. But to me, I feel like it's, I'm going to put on my ER doc hat here, which is what's the question that we need to answer today? And the question we need to answer is, am I infectious right now? And I can think of it in two ways. One is, am I infectious with symptoms? I should be staying home no matter what. With a negative rapid antigen test, I should hopefully be going and getting a PCR. With a positive rapid antigen test, I'm done. If I'm testing myself and I'm asymptomatic for that screening case that Carlos is talking about, a negative test on top of being vaccinated and asymptomatic is pretty darn good for me to feel confident, especially if I do have the resources to do 2 24 hours apart. The lack of access to tests is, to me, one of the very frustrating things about this pandemic. The fact that we were talking about this before we got on, my own hospital is now rationing our rapid moleculars, the things that we use in order to clear people to go to surgery or to the ICU, because we're short on reagents, which is crazy 2 years into this pandemic. And I blame it on the fact that we thought we were done. Right? We thought that the vaccines meant that we were done. We thought that Delta meant that we were done. And so I hope that the biggest lesson that we take away isn't a detailed argument about throat swabs versus nasal swabs. It's about insisting on the fact for us to prepare so that if and when the next surge comes, we're ready.
And I would just add to that I think one of the errors in the US, and I totally agree, is that we put all our eggs in one basket. And the one basket we put our eggs, it's the vaccine basket. And Operation Warp Speed was a success and created a vaccine for us, but we forgot about all the other components. So almost no resources were put in developing therapeutics. We're now beginning to have some therapeutics, but no, the Operation Warp Speed efforts were not dedicated to therapeutics. The Operation Warp Speed efforts were not dedicated to getting tests. All the other things that needed to be done, and we didn't have a broad approach to this pandemic. We said, okay, let's go for the one vaccine. And again, it's very typical of us in the US. We want a simple solution. We want one solution, and that was a vaccine. And I think right now we're paying the price for being so narrow-minded.
I'm going to add on to what Carlos and Megan said. And I think it's not just being narrow-minded. I also think there's two other things that we haven't done well. It's one, we haven't learned from other countries that have done this well during the pandemic. And I think it's also that we've been reactive every step of the way during the pandemic. We haven't prepared. So, that's why we're in the situation that we're in right now with testing. I think, we shouldn't be 2 years into the pandemic and still be having to not be able to find tests, hospitals dealing with shortages of reagents. So I think that's a huge lesson. And I think that moving forward, trying to be more proactive rather than reactive, it doesn't seem that we've learned that lesson quite yet. So I think those would be the other 2 points I would add on.
Can I add one more quick thing, which is please don't come to the ER for your PCR test. If you have symptoms, stay home, call your primary care provider, go to your testing facility. Just stay home. Please don't come into the emergency departments to get tested, just to get tested.
I'm into that.
Well, and also if you have a positive rapid test, don't go out to get a confirmatory test. Stay home. If it's positive, it's positive. So don't go stand in line for 3 hours and infect everybody else.
Let's talk about that for a second, because let's assume you have to be in the hospital because you're sick, because you're positive, right? What do we know about therapeutics for COVID-19 and Omicron in particular? What works, what doesn't work?
Yeah, so I think the biggest questions that have come up with therapeutics for Omicron have been the neutralizing monoclonal antibodies. And so, the one that, so I'm going to talk from the WHO standpoint. The ones that we had recommendations for were the Regeneron product, casirivimab and imdivimab. All of the in vitro studies have shown that it does not neutralize Omicron. So as far as I'm aware, we don't have any animal data, but all the in vitro studies show that it does not neutralize. For sotrovimab, it does look like, at least in the in vitro data, that although it might neutralize at a lower level, it still may be efficacious. So that is good news, and it's still being used. The other monoclonal antibody that I know is being used in the US and we haven't put out a recommendation for yet is Evusheld, and that also does appear to still neutralize Omicron. In regards to the antivirals, molnupiravir, Paxlovid, and remdesivir, there is also in vitro data that shows that those antivirals should also continue to work. And then for the IL-6 receptor blockers and for the corticosteroids, they should not have any effect in regards to Omicron.
Megan, Carlos, have you been using any of these therapeutics, and what's your experience been?
I've been using monoclonals for quite some time. Again, we were all using the Regeneron monoclonal. I was, in fact, one of the investigators in the Regeneron post-exposure prophylaxis study that was published in New England Journal of Medicine. It works, by giving it sub-Q, going to people's home. It works really effectively. We're doing a lot of it. But then, as Kritika said, it doesn't work as well with Omicron. The challenge was at the beginning of the transition, right? Is it Delta, is it Omicron? What do we do? Well, if the only thing we had was Regeneron, we were giving it, even though, you wouldn't injure anybody, and it may help if you got Omicron, but that was a big challenge in the emergency room component, right? Now, and that's where we're doing most of our monoclonals in the ER. Sotrovimab now is the agent of choice. The problem is you can't find it, right? There's not enough out there. So obviously, we now have this very complicated approach of who gets it when. And then, as Kritika said, there's, Evusheld. Evusheld is not for treatment, it's for prevention. And again, very little supply. But if you got your patient with immune suppression, with very severe immune suppression, a transplant recipient, stem cell transplant recipient, that's a good person to consider for Evusheld, because it will give them protection for about 6 months. As far as the therapeutics, I've given Paxlovid to a couple of people. Again, they're hard to get. But if you can find it, it works incredibly effective. I mean, you will see patients tell you 2 or 3 days after, they're feeling better. You got to start it very soon after diagnosis. It has some challenges as far as drug-drug interactions, but those of us working in HIV for a long time are pretty comfortable using ritonavir. We know when to use it, when not to use it, what the interactions are. And as I tell people, it's antiarrhythmics, anticoagulants, rifampin are the drugs you really need to have and the things like transplant drugs, the mycophenolate inhibitors, and after those, then all the other drugs, like for example your statins and everything, you can tell the patient to stop them for a few days and nothing happens. And the nice thing that at least we've seen with Paxlovid is in the clinical trial, it probably also decreases transmissibility because it brings your viral load down. Now, I caution people that none of those drugs has been tested in a vaccinated population. So when the colleague who had infection, who has been vaccinated and boosted, calls that, 65-year-old, 70-year-old colleague with risk factors, calls and says, hey, I'm having symptoms, should I take this drug? You probably can, but we really have no data that it's going to be any better, right? We really don't have the data. And that's, again, going back to what we talked at the beginning. Decision-making with imperfect data is what we're doing now on a regular basis.
Megan?
Go ahead, Kritika, and then I can,
Yeah, and the other thing I was just going to add on to what Carlos said is, so I know molnupiravir has been rolled out here in the US, and the issues with molnupiravir, there are a lot, right? So you have to think about the fact, again, that those studies were not done in people who were vaccinated, and there's a risk of teratogenicity. So you have to put the woman on barrier contraception. And the data is, again, you have to give it early in disease course. And the data, when you look at it all together, I have to be careful what I say here because I've seen some of the unpublished data, but the data is not that great. So you have to do a really, you have to do a risk benefit analysis. And so I think, I think Paxlovid is possibly, you've got the drug-drug interactions, but with molnupiravir, there's definitely the other concerns. And so it's important to keep those in mind if you're going to be giving somebody an oral therapeutic.
I would love to ask a question. Anybody here giving fluvoxamine?
Great question. I've known of it being prescribed once. We couldn't get it. We had to struggle because it was not on formulary, and long story. Have you, Carlos?
I have used it a couple of times. Yeah, I mean, I think, and I've used it also, in patients in Mexico, outside of the country, when people
totally.
It's much better giving that than, for example, giving ivermectin that many people are doing globally. And again, we can talk about, ivermectin has been really the most, prescribed, useless drug in this disease, but we continue to see prescriptions for it globally and also here in the US. So if you're going to do something, I think the data on fluvoxamine looks as good as the data on molnupiravir, quite frankly.
Yeah. So the one thing that I want to emphasize around Paxlovid in particular, which I see is, really, so I'm used to folks coming into the emergency department asking for Tamiflu. I'm fully expecting folks to start coming into the emergency department asking for Paxlovid. I think it's really important for us to be conscious about the fact that it has unbelievably limited availability right now. I put a link in the chat, which is the HHS webpage for looking at kind of local availability of both monoclonal antibodies and Paxlovid, but also that there are really real equity considerations. One of my big fears is that this is going to go to folks with privilege and connections and not to those who need it most and are highest risk. And I think it is our job to be stewards of the distribution of Paxlovid and make sure that it actually goes to those who desperately need that 80% reduction in risk of severe disease, hospitalization, and death, not to those who are the worried well, for whom the vaccines are most likely going to protect them. Because remember, with Omicron, if you are otherwise healthy, if you are vaccinated, particularly if you are boosted, yes, we've said a lot of scary stuff about Omicron, but this is not going to make you seriously ill if you are vaccinated and boosted for the most part. Again, unless you're someone who is in one of those super high risk categories, immunosuppressed, elderly, et cetera.
We have 3 minutes left, but I want to touch vaccines because that's really important. So there's a lot of talk about vaccines and the effectiveness of vaccines against Omicron. When you say fully vaccinated, can you clarify for me, what does that mean?
Oh, I love this question. So I think of it, honestly, at this point in the pandemic, I think of it as that we have our primary series, right? Which is the 2 mRNA vaccines. And then there's the booster. To me, fully vaccinated is that you've completed at this point, you've completed your primary series. And then if now we're saying 5 months out, God knows what it's going to be 2 months from now. But as of right now, if you're 5 months out from finishing that first mRNA sequence, then you get your 3rd dose. I would urge everyone who is at that 5 months out to, again, with the exception of if you're immunosuppressed and then you're eligible much earlier, to get that booster. I would consider that part of your series, just as if you got your tetanus, your Tdap booster 10 years ago, you need to get another booster today. But my 10-year-old who's gotten his 2 shots is fully vaccinated, right? 5 months from now, he's going to need his booster, assuming it's approved. He's going to need his booster. But today he's fully vaccinated.
Carlos, Pratika?
Oh, it's a complicated question. I totally agree with Megan. I do think that in Delta times, I said 2 doses is fully vaccinated. In Omicron times, I think 3 doses is fully vaccinated. And again, that's the change in recommendation as the environment changes, as the virus changes, you have to change the recommendations. And that, I think, is something we need to understand. But I also would say, do we need it for everybody? Don't necessarily think we need it for everybody. Again, I'm thinking about Megan's, 10-year-old. Does he need a booster? Probably not. A young kid may not get very sick. You're probably going to be fine. And then you have to weigh the risk of myocarditis versus the risk of COVID. And that's the complicated risk that many parents have to face right now. So, but in general, I think if you're an adult over the age of 30, and especially if you're over the age of 50, I think fully vaccinated means 3 doses today with Omicron.
And I'll say here, Carlos, I know that all three of us, you, Kritika, and I all agreed early on that those boosters were, in the face of Delta, that it was just taking stuff away from the rest of the world and really weren't necessary for younger, otherwise healthy people. I do completely agree with you that Omicron has changed the calculus, unfortunately.
But that means that also globally, we need to make 3 doses part of what we means fully vaccinated. We cannot have 3 doses in the US and developed countries and 2 doses in the rest of the world. We need to really, that equity means you also need to change that recommendation.
Kritika, last word on vaccines to you.
Right. So, yeah. So perfect segue for me, Carlos, is, I completely agree. So, vaccine equity is a huge issue. And, globally, there's been 9.7 billion doses of the COVID vaccine administered. And over the weekend, COVAX supplied its 1 billionth dose. But as of today, 85% of the population in the African Union has not received a dose of the COVID-19 vaccine. And that is a huge problem. And I think it's important to remember that unless we vaccinate the entire world, we're not going to get out of this pandemic. And, to the points we discussed earlier, we need leadership from not just WHO, not just from CEPI, not just from Gavi, but we need leadership from all countries to help supply vaccine to all of these countries. 36 of 194 member states have yet to vaccinate 10% of their population, and 87 have not met the 40% target. And one of those states is in the Americas, Haiti. Haiti has not even vaccinated 10% of their population, and they're right off there of the coast of the United States. So I just wanted to bring those numbers up because they're hugely important, and we're going to need to fix those if we're going to get out of this pandemic.
And all I would say, I would add to that, it means vaccinating, meaning putting vaccine into people's arms, is not just dropping vaccines at the port of entry and saying, well, hope you can take care of this. It means really getting, so we not only need to get vaccines to places, we need to set up the system in place to vaccinate people. And again, I think global leadership is necessary, and simply the US has just not had it. We did it with PEPFAR, we are able to do it. We need to do it again. And this is an opportunity to really partner with WHO, partner with other global leaders, and really do the right thing to end this pandemic.
Carlos, Megan, and Kritika, I think we can talk for another hour, but we're at the top of our hour, and I wanted to maybe just, in terms of parting words for our audience, all of us have gone through a very difficult time here in healthcare, yourselves included as well. Look ahead for us, words of encouragement. What would you say to someone who's sort of struggling right now, as many people I'm sure are on this webinar? Maybe Carlos will have you start.
Well, the first thing I tell people is thank you. I know how people have worked. I know how hard people have worked. And you cannot say enough to people, thank you for your work and your dedication. The second thing I say is take care of yourself, take care of your family, take care of each other. I think kindness is really important right now. And we need to really be kind to each other and be gentle with each other. And the third thing I would say is remind people that better days are ahead. And if you need to take a break, take a deep breath, but don't kill yourself, because the reality is this has been hard. And as we said, this is not ending anytime soon. So we need to take a breather. We need to take some time off. When people say, I haven't had vacation all this time, well, you have to. We all need a breather. We all need some time off, and we all need to take care of ourselves. So mental health, physical health, really important right now. You're running a marathon. It's time to take a break.
I can't say anything better than Carlos did. Those are amazing maxims to end on. I will say one more thing, which is we all know that one of the biggest drivers, there's lots of talk about, we'll manage burnout with yoga and meditation. And I'm a huge fan of yoga, meditation, exercise, and great sleep. But the reality is that for us to get better individually and as systems, we have to have systems change. And so in addition to being kind and taking care of yourself and keeping hope, because I agree with all of those, I will also say that this is a time to get involved in the larger system, whether it's part of the AMA, part of your hospital committees, working on global vaccine initiatives. It also helps with burnout to feel that you are doing something to change things. And gosh, we need you. We need your voices and hearts and minds, not to do it to the point that you drive yourself to exhaustion. But the only way we're going to get out of this is by changing the way that we're managing it.
I think the only thing I'm going to add to that, I think Carlos and Megan had really great comments, is thank you. I think we all feel the same struggles, the same challenges that everybody else feels. And, I think we are all in this together, and we will get out of this. Sometimes I know it feels like we're not going to, but through camaraderie, through kindness, and through solidarity, we will get through this together. So thank you.
Well, I want to say thank you to the three of you. You've been with us for an hour, but you've been doing this for a longer time, and in venues and places where I only know I can see you on the TVs, but we are grateful to have you here and for your wisdom and your thoughtfulness. We will record this session and make it available to everyone in the department and beyond to see. And we're going to send out resources that we've compiled together based on some of the studies you mentioned to many of our attendees as well. So good night from Denver. Thank you for joining us. And again, we're very appreciative for all that you're doing and for sharing your wisdom with us. Have a good evening. Bye-bye.
Goodbye.